All right, hello everyone. Thank you for attending the first of the Thoracic Surgery Residents Association Journal Club series, which is generously supported through an educational grant to the TSRA from Medtronic. My name is Alex Brescia. I'm an integrated cardiothoracic resident from the University of Michigan. I'd like to welcome everyone on behalf of the TSRA. I'm going to begin by introducing our two faculty guests for this journal club. Dr. Gregg Stone is the Director of Academic Affairs, Professor of Medicine, and Professor of Population Health Sciences and Policy at Mount Sinai Health System in New York. Dr. Stone has served as a national or international PI for approximately 100 multicenter randomized trials, authored more than 2,000 manuscripts and abstracts, and has delivered thousands of invited lectures. He's a lead author for the Excel trial, which will be discussed during this webinar, and is also a director of transcatheter cardiovascular therapeutics, or TCT, and directs a number of courses through both TCT and TVT. Dr. Joseph Sabik is currently the chair of the Department of Surgery at University Hospitals Cleveland Medical Center, and also serves as Surgeon-in-Chief and Vice President for Surgical Operations for the entire University Hospitals medical system. He's a world-renowned clinician and academic surgeon, notably in the area of off-pump and multi-arterial coronary artery bypass grafting. He initially joined Cleveland Clinic staff out of training in 1996 and was appointed chairman of thoracic and cardiovascular surgery there in 2008. He joined the University Hospital System in 2016. He's also a co-author of the Excel trial and currently serves as the secretary of the Society of Thoracic Surgeons. We'll now meet the trainee panelists, beginning with my co-moderator, Dr. Prashanth Thakker. Prashanth?
Thank you, Alex, and thank you, Dr. Stone and Dr. Sabik, for taking an hour off your evening to be here with us. And I want to thank Alex and the TSRA for involving the ACC. I'm Prashanth Thakker. As Alex mentioned, I'm an interventional cardiology fellow at Washington University in St. Louis and the chair-elect for the fifth section of the ACC.
Hi, everyone. Thanks for joining this evening. I'm Zarina Sharalaya, and I'm an interventional cardiology fellow at Cleveland Clinic. And I'm also one of the co-chairs for the Ohio ACC FIT.
Hi, everyone. Thanks, Alex, for inviting me to this panel today. I'm Xiaoxia Lo. I'm currently an integrated clinical fifth-year resident at Emory University. And I was previously TSRA president for last year.
Hi, everybody. My name is Reem Halabi. I'm an interventional cardiology fellow at the Hospital of the University of Pennsylvania in Philadelphia.
And my name is Ray Strobel. I'm a second-year I6 resident at the University of Virginia. A true pleasure to be here. Thank you.
Excellent. So we'll kick things off with our first case. It's going to be presented by Zarina.
All right. So. All right. So this is the case of an 86-year-old male, actually a retired thoracic surgeon who has a history of hyperlipidemia and also a history of idiopathic elevation of his right hemidiaphragm, and previously undergone 2 failed surgeries and a diaphragmatic stimulator in the past. So he actually went into an outside hospital with sudden onset of chest pain at rest, and overall presentation was consistent with an NSTEMI, so they took him to the cath lab. And what immediately jumps out to you in the left system is this distal left main lesion, extends into the proximal LAD, and the prox LAD has this kind of hazy thrombotic looking appearance there. And then in the spider shot, you can see what looks like fairly moderate diffuse disease of the circumflex system, and none of these areas appear to be severely calcified. The right is a dominant vessel, and overall not super exciting, mild diffuse disease overall. So at this point, given his left main disease, they decided to stop and discuss revascularization options, including bypass versus PCI. So they sort of placed a balloon pump as a temporizing measure, and the patient wanted to be transferred to Cleveland for discussion of his revascularization options. So I don't know, Alex, if you want to put up a poll of what you think the most appropriate way to proceed would be.
All right, this should pop up on your screen right about now. Panelists, please also vote. Good, a few more seconds. We got 15 votes out of 25. There we go. A few more coming in.
Could you play that left coronary shot again?
Sure. Let me go back.
And was he troponin positive? You said he had.
He was. He presented with an NSTEMI, yes.
Okay.
You said he was 80 years old, is that right?
86.
86, okay.
All right, so we got some mixed polling results. Most common was actually in favor of CABG, and then a few PCI, and then a few kind of equivocal, saying both would be acceptable.
Perfect. Okay, so in thinking about PCI versus CABG, obviously we're going to discuss this a little bit more, but one of the first things that you would do is to sort of classify his risk from an anatomic perspective. And, you know, anatomically, you would consider the fact that he has this distal left main lesion that extends into the proximal LAD with possible thrombus. Overall, segments aren't super tortuous. There isn't much calcification and the lesions are fairly short overall. There is a little bit of a question as to whether or not the ostium of the circumflex is involved as well, based on their pictures here. So that needs to be sorted out further. But overall, I calculated a syntax score of 24. And unfortunately, the only shots they got of the left system were caudal views. So we can't really see the LAD super well, but potentially here you can see there is maybe some diagonal disease as well, which could bring up his syntax score a little bit higher. But ultimately, this patient had his mind set on PCI due to his concerns personally about prolonged ventilator support or being unable to wean off of the vent given his diaphragmatic issues. And I think that, you know, in his situation, the clinical piece of this is very important to consider and something that I tend to place just as much, if not slightly more importance on, in addition to the anatomic considerations. So overall, his echo showed moderately reduced EF of about 40% with an LAD wall motion abnormality. So all in all, we thought that the balloon pump would probably be sufficient support to perform bifurcation stenting of his left main. So these were our initial shots. We did end up getting a cranial view as well. But, you know, in thinking about bifurcation, left main disease, generally we would prefer a provisional 1-stent strategy as opposed to 2 stents because the outcomes are a bit better with a 1-stent strategy in terms of repeat revascularization. The circumflex is an area that's at high risk of restenosis. So in this situation where we're dealing with left main disease, I think we should make sure that there is indeed presence of or absence of osteal disease there. And I think in this picture, it's pretty clear that he does have osteal disease. And then over here in this cranial view, you can see that there is a mid-LAD lesion as well as a diagonal proximal, probably 70% stenosis that we didn't appreciate before. So to start out with, we interrogated the LAD further with intravascular ultrasound, just to figure out where to land our stents and how big the dimension should be. And just to point out the salient features, the mid-LAD looks okay. And then more proximately, you have pretty soft plaque overall, which is right here in the prox section. Some eccentric calcification overall, and then back into the left main. And then if you look at the ostium of the left main, there is a little bit of disease there, but it's really overall fairly moderate in severity after you calculate the MSA, which came out to be about 10. So this basically tells us that we don't need to stent the ostium of the left main. We can just do the distal portion and then perform bifurcation stenting. And then here we can see the intravascular ultrasound of the circumflex, again, shows pretty diffuse soft plaque extending all the way back to the ostium. So there are many different strategies in terms of what strategy we could use to perform the bifurcation stenting, but in this case, we decided to do a DK crush technique, which I'll go through pretty quickly. So here we decided to tackle the mid-LAD first. So basically placed a fairly short stent across that diagonal branch to perform provisional stenting of the mid-LAD. And then after that, you can see that the diagonal branch is a little bit pinched there, but still with TIMI 3 flow. Then in terms of the next step, we basically stented the circumflex back to the ostium, which is our side branch in the DK crush strategy. And then there's an LAD balloon here waiting for the next step, which would basically be to crush the side branch stent struts with the balloon and the LAD. And this is what we're left with after that step. Next would be the kissing balloon inflation with 2 balloons of equal size in both branches, removing the circ wire and then performing our main branch stent into the LAD back into the left main. Then we do our second kissing balloon inflation, and then last step being the proximal optimization technique or POT of the left main. And then here are our final angios. And then for completion's sake, you can just see our final IVUS result of the LAD left main stent. So overall, pretty good stent expansion, stent acquisition. And that is my case.
That's great. Thanks, Zarina. I don't know if you were personally involved with it. It sounds like from what you said from the discussion that the patient was pretty set on, PCI and avoiding surgery. Just out of curiosity, if you were there for the discussion, do you know, was it presented to him as, either CABG or PCI would be reasonable, and then he kind of had strong preferences, or did your team recommend PCI or recommend one or the other?
Yeah, I mean, we definitely presented both options to him. CT surgery was very thorough with their evaluation and said that it would be doable, but given his background as a thoracic surgeon too, he had his own concerns about being on a ventilator prolonged. So it was really kind of obviously his decision at the end of the day, but both options we considered to be reasonable.
Right. And then it's always interesting because whenever we have these discussions and everything about the syntax score in actual practice, I think as surgery residents, we never calculate the syntax score. I don't know if you do, Xiao, but it's kind of like we have the patients that we're going to operate on, and they may or may not even have a syntax score in their note. But just out of curiosity, based on the information from when you went for the intervention, what would his syntax score have been? I know you mentioned the LAD disease. It might have bumped it up a little bit.
Yeah, so with that LAD lesion, it would have bumped it up to low 30s. So.
All right, and then I would just open to Dr. Stone, Dr. Sabik, if you're willing to share your poll votes and kind of your overall impressions about this one.
Oh, I think you're muted, Dr. Stone. You're talking.
Okay, great. Sorry about that. So maybe I'll go first. So this is an interesting case for several reasons. I agree that this was probably a, quote, intermediate syntax score case. I do think there was diagonal disease as well. But this is where I think it's actually really helpful to have a discussion with the cardiac surgeon and with the patient. My main concern when I first saw the film, which is why I asked you to replay it again, was actually not the distal left main bifurcation disease, which I think you treated perfectly with the exact same technique that I would have chosen, but whether there was or not a large amount of thrombus. And in that one view, it looked like a large amount of thrombus. I couldn't say 100% it wasn't calcium, but given the non-STEMI presentation, it looked like thrombus. And that's not a location where you want to have a lot of thrombus when you're putting overlapping stents in place. And for that reason, surgery would be a reasonable option if we did believe that was thrombus, and or if I was going to do it interventionally, I would probably want to treat the patient for 48 or 72 hours with a drug such as Cangalor or a 2B3A inhibitor. When you brought the patient back, I'm not sure how many days later it was. I don't know if he was kept on heparin or not, but it didn't seem like there was any thrombus. So it seemed like whatever
Exactly.
there was resolved. Then the last thing I'll say is that, I had to ask you to keep replaying the films. And Joe Sabik probably saw this case in 2 seconds. He knew that he could bypass it because all he had to see was the distal targets. I had to look at all the details of all that anatomy that you were showing me. And that's the difference between interventional cardiology and cardiac surgery. For Joe, the considerations, and he'll talk about, are different. It's more his age and this issue of the elevated hemidiaphragm and what the risks of prolonged intubation and pneumonia would be because of that. So I think this would be a great case for the interventionalist and the surgeon to talk over those risks of safely getting the patient through the procedure based on how much thrombus is there versus the surgeon can obviously, the targets were great, could easily do a bypass here, but then has other procedural complications to worry about. So, and then ultimately you bring that to the patient and you let the patient's preferences help dictate the decision.
Yeah, all great points. I think, with the thrombus, it definitely looked like a huge chunk of thrombus on their outside hospital films. And that's one thing that we were concerned about, what is that going to look like now? He was kept on heparin for about 5 days between that time. And so when we took our initial angios, it looked like that had resolved actually. So, and on IVUS, it's hard to differentiate plaque versus thrombus on IVUS, which is a whole nother thing, but at least angiographically, it looked like it had cleared up.
Yeah, so first of all, great case and wonderful results. And I think, Greg kind of hit on the point that I wanted to make. I think when we look at this case, there are kind of 2 different sets of risk factors, right? There's risk factors that are more important for an interventionalist and risk factors that are more important for a surgeon to consider. And when we think about intervention, it's really the complexity of the coronary artery disease. And when we think about a surgical procedure, it's really the comorbidities that the patient has. And actually, Greg, you may remember this, but a while back at a left main summit, I did a little analysis of looking at syntax data by both PCI and surgery. And what you see is that as the syntax number increases, the risk of surgery doesn't really change. It's relatively constant. But we know that as the syntax or complexity of coronary artery disease increases, the risk of PCI increases. And so it really is kind of different. And, we're often in these discussions or panels, thinking that PCI and surgery are competitive procedures. They're not competitive procedures. They both play an important role, as I think demonstrated in this patient. I have to admit, when I looked at that angiogram, I said, geez, that's really complex disease. I'm not sure an interventionist is going to want to take that on. Again, there's the diagonal disease, there's the LAD disease, and I don't know if that high circumflex branch was jailed by the circ stent. And as Greg said, I looked at it and said, yeah, these are really nice targets. I know he's got some pulmonary dysfunction, but I could do an off-pump CABG in this guy, or maybe even consider some type of hybrid procedure where if we're really worried about his respiratory function, do we put a lima to his LAD through a mini thoracotomy and then have them go ahead and stent the left main down into the circumflex in maybe a safer option. So again, I think that, it's thinking about the risk factors. Comorbidities apply to surgery, complexity of disease apply to PCI. How do we balance those 2 out so that we get the best outcome for the patient?
It's funny that you said that, Joe, about the hybrid option, because I was thinking that myself. If I brought this patient back after 5 days and I still saw that massive amount of thrombus in the distal left main and proximal LAD, I don't think I'd want to put a stent in that. So actually, I was thinking of potentially asking the surgeons, can you, through a on-pump procedure or off-pump procedure, just drop a lima to the LAD? And then we could treat the circumflex a month from now, once the thrombus resolves. I think that would have been actually an elegant way to get around that problem.
I think in terms of his pulmonaries, I know this was kind of an acute event, but did he have any PFTs or anything, or what was his respiratory functions like? Because I think we've all operated on people with diaphragmatic paralysis. Obviously, if the right is paralyzed, that's a worse situation than the left. And I think in this gentleman, it was his right. So I do think it's important to be cautious, but we've all operated on those situations and patients have done well. I don't know if you had any assessment of his pulmonary function preoperatively.
We did, yeah. It was about moderately, his lung volumes were moderately reduced. So, you know, it would have been a little bit risky, but again, I think that the surgeons would have been willing to give it a chance, so.
Thank you.
Sorry.
No, I was gonna say, the last thing I want to say is, from an interventional point of view, this was a moderately tricky case. And so I think it really does depend on the experience and expertise of the operator if they're comfortable doing a distal left main bifurcation with a DK crush technique, IVUS guided as you did it, which was beautiful, and you got a great result. But I can tell you, I doubt, I do think the data is best for DK crush, but I doubt that probably 10% of the interventionalists in the country have ever done a DK crush, because we've got the average interventionalist doing 30 cases a year and probably doing no left mains. So it really depends on the local expertise also of the center that you're at, to be able to interventionally take on a case like this.
Serena, do you know if, was it just a traditional CABG that was offered to the patient, or do you know if there's any discussion of a hybrid option? Or
We actually, I don't think even in my general fellowship, I have never seen a hybrid approach actually. I'm sure maybe it's been done. I'm sure it has, but it's not a common thing. And we didn't discuss that. So
right.
It's a reasonable thing to consider for sure.
All right, great. We move on to the second one. Xiao, if you want to take it.
See if I can see it. Can everyone see that okay? Okay, great. Okay, hopefully I'm not muted either. So, so this is a patient who's 80 years old. He has not many medical problems, just hypertension and some GERD, no significant past surgical history. He presents with a history of chest pain, unstable angina. He had a stress test that was done by his cardiologist that demonstrated a perfusion defect in the inferior apical region that improved with rest. He had a left heart cath that was obtained as an outpatient. Excuse me. So let me go ahead and show you that heart cath. So on the spider view, we see a distal left main target that's about 99% stenosed. Go back to the next one. On the RAO caudal view, we see that it's, it's a small circ and marginal system, but no significant disease there and no significant disease in the LAD. I think I have a better shot of that coming up here. Reasonable target without significant disease. And our right shot showed a mid lesion of about 90% occluded with a pretty sizable PLV branch as well. So the significant left heart cath findings, we had a tight left main, 99%, no significant diseases in the other vessels on the left. His right dominant with a mid 90% stenosis. His function looked to be intact, although we did not have a pre-op echo. So at presentation, he had a balloon pump that was placed in the cath lab when they found the left main disease, and he was transferred to our institution. At that point, he was chest pain free. He had no EKG changes. His strokes were negative. He had a normal BUN and creatinine, and his BNP was just 50. So I did not do a syntax score. We're not, as Alex alluded to, we don't really normally calculate a syntax for these patients, but based on kind of what we talked about, he's probably in the low category, low to intermediate category, and would be a low risk surgical patient as well. So do you want to do your poll, Alex, or?
Yeah. All right, so same question. Should be popping up on your screen right now. Give a few more seconds. Any last votes? Okay,
All right.
looks like cabbage, and then a smattering of either would be acceptable, and then a handful of people favoring PCI. All right, go ahead.
Might be related to our audience composition too. So we did proceed with cabbage. We did a cabbage ×3, Lima to LED, a vein graft to an OM, and a vein graft to that nice PLV branch that you saw. His post-op course was pretty uneventful. He was brought to the ICU in stable condition, passed his balloon pump trials, morning of day 1, which was removed. He was extubated, weaned off all drips by post-op day 2, transferred to the floor, and was sent home by post-op day 5. So he did great. So before we, go on to, Rim and Ray are going to talk about the trials and the main points of these trials, I wanted to, I guess, frame the discussion a little bit, and hopefully our panelists can also weigh in on this as well. But, the discussion here is that PCI and CABG are not competitive. Like Dr. Sabik was saying, they're complementary procedures. PCI is treating a single lesion. CABG is supplying territories, and those are rough percentages there. And CABG does bypass present and future threatening lesions and decreases the need for repeat revascularizations, which we do know on syntax data also increases, is an independent predictor of MACE. And then I wanted to highlight, to frame that discussion, that both Noble and Excel, when we talk about it, it's on selected patients. So with the Excel population, most of those had low to intermediate syntax, or all of them had low to intermediate syntax scores, with only 51% with disease other than left main. And Noble had predominantly solo left main disease as well. And the breakdown was predominantly, 92% of those patients were in the low intermediate category, which is, I think, both of the cases that we shared today were in that category. So this is a slide I borrowed from Dr. Guyton. And CABG remains unchallenged by RCT data in more than 60% of left main patients. And the population that we're trying to address is actually that population, that about a third of the population where PCI and left main would both be amenable. And I'd love to hear the panelists take on that as well. And that's it. I'll pass it over to you here.
Well, great. Well, this is Greg, so maybe I'll go first. So again, very nice case. And I think CABG was very reasonable in this case, certainly. You did have a few things wrong on your slide about Excel, though, so I'll help you with that. So about 90% of the patients had disease outside the left main, not 51%. So about half the patients had multivessel disease. And again, isolated left main disease was pretty unusual. And while by intent, we actually planned to only enroll patients with low and intermediate syntax scores, actually a quarter of the patients had high syntax scores by core lab analysis. And that's because sites always underestimate the syntax scores. Now, those were the lower end of the high syntax scores. They were, between 33 and 40. So they're certainly not the most severe cases. And the operators felt that they were intermediate risk, but they were still on the high side. So that being said, in this case, I think this case would have been fine for PCI or CABG. There were really only 2 lesions. It was predominantly a mid-shaft left main lesion. It did look heavily calcified to me. So if that was the case. And so the interventionalist would need to be very comfortable with atherectomy or other techniques to treat that subtotal left main. But the restenosis rate would be very low in that left main coronary artery. And there was a focal mid-right coronary stenosis, which would have been very, very easy to treat and would have had a probably 1 or 2% restenosis rate. So the differences here, I think, is that both procedures could have safely gotten the patient through the procedure. I think PCI would have been a little easier for the patient, but as you alluded to, bypass surgery does offer greater durability, particularly I think in terms of late myocardial infarction. By bypassing all those uninvolved segments, those areas that angiographically were 10 to 20% stenotic, some of those probably had substantial plaque if you were to do intravascular imaging in all of them, and some of those will progress. and might cause a myocardial infarction. Probably in a case like this, overall, the major differences 5 years down the road are not all that different. So I think I would have given the patient an option, but I would have discussed the somewhat easier upfront course with PCI, but the greater durability with bypass surgery.
Yeah, so I think that when we think about any study, we always have to think about bias, because there's always bias in study design. Even in a randomized study, and the bias occurs on the patients that are entered into the study. And I think you pointed out, very nicely that both studies included selected patients. And one of the things that we did do, and the surgeons and the interventional cardiologists agreed at the beginning of Excel, that we would have a registry. Not exactly like the registry in Syntax, but the first 1,000 patients we looked at to see, who did not get entered. Because again, you could have a low Syntax score, but there still could not be equipoise on both sides. For instance, the patient could have a lot of severe comorbidities, and therefore we would think that there isn't equipoise here and that patient's better treated with PCI. Or they could have really complex disease that maybe wasn't reflected in the Syntax score, and that patient referred to surgery. So I think your point about understanding, selection is a very important one, and I think, tested very well in studies like Excel and Syntax. I think the slide that Dr. Guyton showed you is very interesting. There have been other studies that kind of looked at, kind of the universe of left main or patients having surgery, and what they looked like anatomically prior to when PCI was common in left main. And what we see is about 50 to 60% of those patients have triple vessel disease with left main, and another 10 to 20% have double vessel disease, and maybe 10% have single vessel disease. And it's only a small minority that have isolated left main. So again, although I respect Gregg, and Gregg knows the data and the outcomes better than anyone I've ever met, I do think that the studies are not really completely reflective on the universe of left main disease, and do kind of agree with Dr. Guyton that probably 2/3 of patients really aren't even tested in these studies, which is kind of interesting. But either way, when I looked at this and I said, oh, wow, this is another patient we could do a hybrid on, because this one seemed to really have discrete lesions where you could put the Lima to the LAD. The stent looked very, the right looked very stentable from a surgeon's point of view. And then that circ wasn't too big. And so you could think about putting a stent, again, and this is a surgeon, through that left main into the circumflex and maybe get it taken care of. The one thing I didn't catch in the case that was, and I probably missed it, the age of the patient and whether he had a lot of comorbidities, because that might, again, deter you. Again, I think this guy had a lot of options. I think a hybrid might have been really nice for him, and I think you could do, standard surgery. But I was not sure how big that circumflex was.
Patient was 80 and he had pretty low comorbidities, so probably a low STS risk score. And I think Dr. Haukos was out that day, so he wasn't part of the hybrid discussion, but he may have been a candidate for that instead. But I appreciate the discussion. The last two slides are meant to be provocative, especially for the cardiologist, so appreciate that.
One thing that I started thinking about while we're discussing this is kind of an analogy with lung cancer, where you have a clinical staging and then do the operation, and you have a pathological staging, and sometimes patients get upstaged. I don't know if there's data, and again, we don't look at Syntax scores regularly, but if there's data in terms of patients having an initial Syntax score from their diagnostic cath, and how much that changes at the time of intervention, or if that's even calculated, sort of like a rescoring when you have different or enhanced views, and if that gets incorporated into any of the trials or otherwise.
No, not really. I don't think, to my knowledge, no one's really looked at that. Often, as you actually saw in the first case, the diagnostic film done through diagnostic catheter is often suboptimal compared to when you're injecting more dye through a guide catheter. You get much better pictures. And of course, in the first case, you saw the change with the thrombus resolution over time, which would get taken into account. So I think what's interesting about both of these cases is that, and I think Joe would agree, Joe, both of these cases would have been eligible for the Excel trial. Except for possibly the diaphragm issue in the first case, it would have depended if the surgeon would have agreed that that patient would have been eligible for surgery. If at the local site, the surgeon would have agreed, then that patient would have been eligible for enrollment in syntax, in Excel. And the second case certainly would have been eligible. And I think that, in Excel, we found perhaps some small differences between PCI and CABG, but at least choosing those patients with mostly site-assessed low and intermediate syntax scores, who the surgeon felt was a good candidate and the interventionalist felt that he or she could do the case successfully, the differences over 5 years were really pretty small. I mean, you're talking about a 0.3% difference in 0.3% per year difference in death, 0.4% difference in MI, 0.2% difference in stroke. There's an important difference between statistically significant differences and then really clinically relevant differences. I think most importantly, both treatments actually did pretty well for the vast majority of the patients.
Great. I think that's a good segue into the final two short presentations on the 5-year data from Excel and then Noble. You can go ahead, Reem. Yep.
Thank you very much. And thank you everybody for your time tonight. Can you see my slides?
We do.
Yes, perfect. Thank you. So as Alex mentioned, I will be presenting the 5-year outcomes for the Excel trial that was published in the New England Journal of Medicine in 2019. So Excel was an international open-label, multi-center, non-inferiority randomized clinical trial that evaluated PCI versus CABG in the treatment for left main disease. Eligible patients were those with left main stenosis more than 70% or left main stenosis 50 to 70% with evidence of hemodynamic significance on invasive and non-invasive testing. The syntax score was 32 or less, and there was consensus agreement by the heart team that patients are eligible for both procedures. A total of 1,905 patients with left main disease were randomized to either PCI or CABG, and clinical follow-up was performed at 1 month, 6 months, and yearly through 5 years. 5-year follow-up was available for 93.2% of patients in the PCI arm and 90.1% of patients in the CABG arm. The primary outcome was the composite of death from any cause, stroke, or MI at 5 years. Among the 948 patients who were randomized to the PCI arm, a total of 935 underwent PCI, 7 had CABG, and 6 had no revascularization. And among the 957 patients randomized to CABG, 923 underwent CABG, 17 had PCI, and 17 had no revascularization. Overall, the baseline characteristics were well balanced between the two arms. In this table, I summarize a few of those. Diabetes was present in 30% of patients in the PCI group compared to 28% of patients in the CABG group. Congestive heart failure was also equally represented. Recent MI within 7 days was present in 14% of patients in PCI and CABG groups. And the mean left ventricular ejection fraction and the syntax scores were overall very similar between the two groups. This table summarizes the primary and secondary outcomes at 5 years. First, I'll draw your attention to the primary outcome, which was the composite of death, stroke, or myocardial infarction. The event rates here are Kaplan-Meier estimates from the time to event analysis. And as you see here, there was no difference between PCI and CABG when it comes to the primary composite endpoints at 5 years, with an event rate of 22% in the PCI group compared to 19.2% in the CABG group. And the odds ratio was 1.19 and a 95% confidence interval that crossed 1. When ischemia-driven revascularization was added to the composite endpoint, that is one of the secondary outcomes, which is death, stroke, MI, or ischemia-driven revascularization, there was a higher rate of the primary endpoints in the PCI group at 31.3% compared to 24.9% in the CABG group. And the odds ratio was 1.39. For death, the event rate was 13% in the PCI group compared to 9.9% in the CABG group. There was no difference in stroke between the two groups, with rates of 2.9% at 5 years in PCI versus 3.7% in CABG. For the total myocardial infarction, also there was no difference between the two groups, with 10.6% in the PCI arm versus 9.1% in the CABG group. There were two types of myocardial infarction, peri-procedural and non-peri-procedural. For peri-procedural MI, the rates were in favor of PCI, with 3.9% compared to 6.1% in the CABG group, whereas for the non-peri-procedural MI, the event rates were in favor of CABG with 3.5% compared to 6.8% of the PCI group. For ischemia-driven revascularization, the event rates at 5 years were higher in the PCI group at 16.9% compared to 10% for the CABG group. And this is with an odds ratio of 1.84. This table summarizes additional outcomes at 5 years. Stent thrombosis event rate was 1.8% in the PCI group, and symptomatic graft stenosis or occlusion was 6.5% in the CABG group. Therapy failure, defined as definite stent thrombosis or symptomatic graft stenosis or occlusion, happened in 1.1% of patients in the PCI arm compared to 6.5% in the CABG group. Cerebrovascular events, stroke or TIA, occurred in 3.3% of patients in the PCI group compared to 5.2% in the CABG group, with an odds ratio of 0.61. Here are the Kaplan-Meier curves for the primary composite endpoint of all-cause death, stroke, or MI. As I mentioned earlier, the Kaplan-Meier event rates were 22% for PCI and 19.2% for CABG, with an odds ratio of 1.19 and a confidence interval that crosses 1. I'd like to draw your attention to how the curves cross in the middle. Before the curves cross, the event rates were in favor for PCI, and afterwards they're in favor for CABG. For the hazard ratios, PCI versus CABG for the primary outcome, they varied in 3 periods. Here I'm showing you period 1, 2, and 3. Period 1 is 0 days to 30 days. Period 2 is 30 days to 1 year, and period 3 is 1 year to 5 years. If you look at the first part of the graph for period 1, at 1 month, the event rates for the primary endpoint were 8% for CABG compared to 4.9% for PCI. During period 2, the event rates were similar across the 2 arms. And for period 3, the events rates were higher in the PCI group at 15.1% compared to 9.7% in the CABG group, with a hazard ratio of 1.61. These 2 tables summarize the primary outcome with their components in period 1 and period 3. So as I mentioned earlier, in period 1, the event rates for the primary endpoint was 4.9% in PCI, which is lower than that in CABG at 8%. There was no difference in death and no difference in stroke rates, and myocardial infarction occurred less peri-procedurally. Here total myocardial infarction with a rate of 3.9% in PCI compared to 6.3% in CABG. In period 3, which is from 1 year to 5 years, the primary endpoint occurred in 15.1% in the PCI group compared to 9.7% in the CABG group. Death, the estimates at 5 years were 10% compared to 6.6% in PCI versus CABG respectively. There was no difference in the stroke rate. And for myocardial infarction, the estimates at 5 years showed a higher rate with the PCI group at 5.1% compared to 2.4% in the CABG group. In the next few slides, I'll show you the Kaplan-Meier curves for the different components of the primary endpoint. So here's the time to first event curve for all-cause death. At 5 years, the rates were 13% versus 9.9% for PCI versus CABG, with an odds ratio of 1.38 and a 95% confidence interval of 1.03 to 1.85. This is the time to first event curves for stroke. The event rates was numerically higher in the CABG group at 3.7% compared to 2.9%, and the odds ratio was 0.78. This is the time to first event curve for MI. At 5 years, the estimate rate was 10.6% in the PCI group compared to 9.1% in the CABG group. Overall, no difference. But again, we see the curves cross here, similar to the primary endpoint. Initially, before the curves crossed, the event rates were in favor for PCI, and that was reversed after the curves crossed. And finally, this is the time to first event curves for ischemia-driven revascularization, showing higher rates at, with PCI at 16.9% compared to 10% in the CABG group. In this table, we see the subgroup analyses of the primary composite outcome at 5 years. There were overall no differences in the relative risk for the primary endpoint in PCI versus CABG for the pre-specified groups. So in summary, there was no significant difference in the composite rate of death, stroke, or MI at 5 years among patients with left main disease with low or intermediate anatomical complexity who underwent PCI versus CABG. There were 3 distinct periods of relative risks: 0 to 30 days, where fewer primary outcome events occurred in the PCI group compared to CABG; period to 30 days to 1 year, during which the incidence of the primary composite endpoint was similar between the 2 groups; from 1 to 5 years, where fewer primary outcome events occurred in CABG compared to PCI. There were numerical differences between PCI and CABG in several non-powered secondary outcomes. The event rates for death from any cause and repeat revascularizations favored CABG, and event rates for cerebrovascular events and therapy failure, defined as stent thrombosis or graft failure, favored PCI. And finally, the rates of myocardial infarction at 5 years were similar in the 2 groups. The rates favored PCI in the periprocedural period and favored CABG during the long-term follow-up. Thank you very much for your attention.
Thank you, Rima. That was great. Obviously, a lot to unpack there. If we can, we'll go right on to Ray, who I think for about 5 minutes will tell us Noble, and then we can have a short discussion. I know there's at least one audience question, and there are a couple audience members who texted me questions, which I'm gonna tell them to put in the Q&A. So go ahead, Ray.
I'll mute myself there. Thanks again for the opportunity to present the 5-year results of the Noble trial today. As we know, following the results of the Syntax trial, guidelines in both Europe and the United States were revised to recommend PCI for patients with left main disease and favorable anatomy. And as again, we all know, this recommendation was really based upon subgroup analyses from Syntax, as well as several other smaller randomized trials, none of which were adequately powered to demonstrate non-inferiority for PCI relative to CABG for this indication. And so the Noble trialists sought to test the hypothesis that PCI is non-inferior to CABG for left main disease. And in order to do so, they devised a non-blinded, randomized, non-inferiority trial, which sought to enroll patients with stable angina, unstable angina, or ACS, all of those having a lesion of greater than 50% on angiogram or an FFR of less than or equal to 80% in the left main. And of course, patients who presented with STEMI, patients deemed excessive risk for either procedure or whose survival is estimated to be less than a year, or who had more than 3 additional lesions were excluded. Their primary outcome was a composite of all-cause mortality, stroke, non-procedural MI, and repeat revascularization. Secondary outcomes included 30-day mortality and stroke, as well as therapy failure. And the analysis was approached with an intent to treat methodology. Ultimately, the Noble trial enrolled 1,184 patients across 36 European centers from December 2008 through January 2015, and they achieved a median duration of follow-up of 4.9 years at the 5-year follow-up publication point. And looking at the cohort that they ultimately enrolled, it certainly was well balanced. Some highlights of this cohort: only 22% were women. Diabetes was only present amongst 15% of the cohort. Importantly, 20% of either arm had already undergone some PCI prior to being enrolled. And perhaps most importantly, the median syntax score of this cohort was 22.5, with only 9% of the cohort being of high syntax score and the majority being of a low syntax score. Drilling down into the treatment arms, looking at the CABG arm, the majority underwent on-pump CABG, with essentially all patients receiving an arterial graft to the LAD, and essentially none of the patients receiving only one graft. So 96% of the patients receiving 2 or more grafts, one of those being to the LAD. Turning your attention to the PCI arm, 92% of those patients received a 2nd-generation stent, and the majority received treatment of an isolated lesion. And so at 5 years, the trialists did find a significant difference favoring CABG in this trial. And specifically, they found that patients who underwent PCI for left main disease were 1.58 times more likely to experience the composite outcome of all-cause mortality, non-procedural MI, repeat revascularization, or stroke relative to CABG. And so that was 28.4% in PCI versus 19.0%. And you can see that on the left-hand side here. When they broke the outcomes from the composite down individually, this effect appeared to be driven primarily by increased rates of non-procedural MI and increased rates of repeat revascularization amongst the patients in the PCI arm. And critically, the rates of all-cause mortality and the rate of stroke actually was not significantly different between the PCI arm and the CABG arm. And it's also important to emphasize that in this trial, the rate of therapy failure at 5 years was not significantly different between PCI and CABG. Therapy failure, again defined as graft occlusion or stent thrombosis. And so interestingly, the authors then went ahead and stratified their cohort by syntax score, low, intermediate, and high, and then ran the analysis again. And what we see here is that the effect favoring CABG is actually its strongest amongst patients who are low syntax score. And that among patients who are intermediate or high syntax score, although the effect is not statistically significant, as you can see from the figures here, the effect does appear to favor CABG relative to PCI for that primary composite outcome. And this table just goes to show that in all the other subgroup analyses, that the observed effect of the difference in primary outcome between PCI and CABG was not different. So some caveats or limitations about this trial. 8% of the PCI patients did receive a 1st-generation stent before switching over to that 2nd-generation stent. In contrast to Excel, periprocedural MI was not included in the composite. Again, in contrast to Excel, syntax scores here were lower, and a greater proportion of patients presented with stable angina. And of course, this is a study conducted amongst European centers, so it may not be completely generalizable to the United States experience. And so in summary, in the Noble trial, PCI was associated with a significantly greater hazard of MACE relative to CABG. And this was primarily driven by repeat revascularization rates and non-procedural MI revascularization rates. These findings were consistent across all syntax subgroups and ultimately suggest that PCI may be inferior to CABG in the treatment of left main disease. And thank you very much.
Thanks, Ray. That's great. Prashanth, maybe you want to ask the first question we have from the audience, and then Drs. Stone and Sabik can kind of integrate their response to some of what was presented into that.
Absolutely. Thank you again for the presentations, and this was great. You know, the biggest, I think one of the differences between the Noble and Excel trial was, again, looking at the primary outcome was immediate peri-procedural MI, and I know there's been a lot of discussion about this, and Dr. Stone, you've talked about this before as well. And one of our first questions by one of our audiences is, again, trying to elucidate the definition of that, and I know the SCAI definition clearly points out what that is, and if there was any validation that peri-procedural MI would be clinically significant in these patients going forward.
Yeah, so we've published extensively on that. The procedural myocardial infarction definition that was agreed upon by the interventional cardiology and cardiac surgical leadership was one of a large, extensive myocardial infarction. So basically, we only use CKMB to evaluate post-procedural myonecrosis, which I think is substantially more accurate than troponins. And it had to be basically greater than 10 times the upper limits of normal from a normal level, or 5 times with major findings such as new Q waves. And we've shown that both after PCI and after CABG within the XL trial, that was correlated as a multivariable independent predictor of subsequent cardiovascular and all-cause mortality with similar prognostic relationship after both PCI and CABG. So that was a major difference between XL and Noble. And Noble, they didn't calculate peri-procedural MI. They couldn't, I've talked to the investigators about it, and they couldn't agree on what the definition should be. And they said they don't look for it anyway in clinical practice, so why should they do it in a trial? So they decided not to. But in a post hoc fashion, they were able to collect CKMB data in 60% of their patients. And what they actually found was something not dissimilar from Excel. The peri-procedural MI rates were 5% after PCI and 7% after CABG, using that 10 times cutoff.
Thank you, Dr. Stone. And I think in addition to that, I actually had a question about looking at similarities in Excel and Noble. And as we look at the 5-year data, we see that repeat revascularizations diverge, and there's more in the PCR arm. And we talked about supplying territories and areas as opposed to treating lesions. The question I had to follow up on that is, if you look at the Noble data, total repeat revascularizations was about 17%, 97. And total lesion revascularization, which was previously intervened on, was almost 12% of that, 67 of those were that. So when we look at the underlying qualities of these patients, a lot of them had calcific disease, almost 42% of patients in Noble. Bifurcation techniques that were used were Colot in 24%, and IVUS was used in about 40% pre-procedure and 70% after. I wanted Dr. Stone, you to comment on procedural techniques in these patients. Obviously, there's a lot of data on how we approach bifurcations, imaging and physiology, and really determining TLR rates going forward. So there's obviously a lot of heterogeneity there.
Yeah, it's hard to compare one study versus the other, in detail for that kind of a question, but there are some clear differences. The syntax scores were higher in Excel than in Noble, about 26 versus about 22. The Excel used mostly second-generation drug-eluting stents. Noble used mostly first-generation drug-eluting stents, particularly the biomatrix stent. The choice of distal bifurcation techniques was somewhat different between Excel and Noble, and more intravascular ultrasound imaging guidance was used in Excel compared to Noble. That being said, I think the interventional techniques in Excel could have been improved upon. We could have used more physiologic guidance to select which additional non-left main lesions should have been intervened on. I think IVUS should have been used in 100% of all the left main cases, and the data really supports doing that. There was almost no DK crush done, no crush techniques done at all in Excel, and I think that could have been improved upon. And I think that, in the future, not today, but in the future, we'll be looking at vulnerable plaques, and we might be able to do better in terms of even those late MI events. But all that being said and done, I think the results of Excel and Noble were actually more alike than different. They chose different endpoints, right? I mean, the fact that the Noble investigators didn't include procedural MIs is bizarre to me. And they did include revascularization in their primary endpoint. We had it in a secondary endpoint. We had a large enough trial in Excel that pretty much everybody agreed revascularization was of secondary importance compared to death, stroke, and large myocardial infarction. It's not more important than renal failure or new onset atrial fibrillation requiring prolonged anticoagulation. We could have included those in the primary endpoint, but all those were secondary endpoints. But nonetheless, if you look at it, procedural MIs tended to be less after PCI in both studies. Non-procedural MIs were more after PCI. Revascularization was more after PCI, about 6% in Excel and 7% in Noble. The stroke rates were low. Early stroke rates favored PCI. And the mortality was, there was a small difference in Excel and no difference whatsoever in Noble. So the results were really more similar than they were different. And I think trying to parse it any more than that is probably not going to be useful.
One other question from Jason Hahn is a good one. And he said, thanks for your time as a trainee. He wonders what the next steps will be in our practices. So in terms of, what trials are in the pipeline, what points of equipoise are going to be focused on for the next set of trials on coronary disease or specifically left main disease?
Well, maybe Joe should answer that. Not necessarily what's going on, because there's really nothing going on in terms of ongoing trials, but it'd be great to hear from Joe what additional studies or trials he thinks should happen. And what other questions, should we address? Have we enough funding and the guts to do it again?
Thanks, Greg. I appreciate the softball. That's a tough question. I mean, I think that one of the things that amazed me during the Excel experience was the amount of work and time. I think, we started talking about this, Greg, in 2008, and it's now, 12 years, 13 years later. And I think, a lot that we learned, and I should say I learned, through this process. And one of the things I think we keyed upon, and I think Greg put it in really great perspective, it's not just about looking at how the study defined its composite endpoint. It's really looking at the endpoints and getting an understanding of it. And so today we're kind of in a position where we have a lot of studies. Now, one of the reasons we do composite endpoints is because we just don't have enough patients to power looking at mortality or looking at MI alone as our primary endpoint. But we have several studies now where we can put together and then really look at mortality, really look at MI, really look at stroke, because we can have the power, to do that. So what I would say is I think we need to maybe not do another study, maybe take a step back and, do some meta-analysis and obviously, at patient level data. And there's a lot of work in process to try to get that accomplished, and getting all these groups to work together to solve that. And I think that would be, very helpful. When we came together in 2008 to work on Excel, it was really about trying to do as meaningful a study as we could by looking at what we felt were the most important endpoints. And I think, there have been some, question, to those endpoints, particularly in the definition, but how you define the endpoint, seems to me to be obvious, can influence the outcomes of the studies. And so I think these are some of the things we learned. I think we're a lot smarter. I think one of the other things we learned and has been so well demonstrated by all of you is, again, these are complementary procedures. We can learn so much. We know that initially surgery has risk. In that short period, there's not too much difference, but when we get long out is really when the benefits of surgery seem to demonstrate themselves. So you have patients in your practice, the 86-year-old who has, comorbidities. You might not need a 10-year result for that patient, but you do need a few-year result for that patient. And so stenting and PCI tends to be appropriate. You have the 55-year-old that maybe has an intermediate risk, intermediate syntax score without comorbidities. You're going to push that patient towards surgery, I think, because we're really looking, to get long-term results with that patient. So again, I think there's a lot in the studies, you know, that you can unpack and learn. And I think, as Gregg has said so nicely, when you look at Noble and Syntax and you really pull back the sheets, you find out that they're pretty similar, and that it helps guide us into what's the best treatment for the patient in front of you at that time.
I think those are great points. One of the things you said, Dr. Sabik, about kind of looking at the data, doing meta-analyses now that we have all these trials. One of the recent meta-analyses, and this just came to mind because we talked about it recently at my institution, was Dr. Gaudino and colleagues did it for the all-cause mortality, or kind of all-cause and cause-specific mortality as a meta-analysis in JAMA Internal Medicine. And I know that's been debated a lot from Excel. It was one of the secondary outcomes, and it was statistically significantly different. And there's been debate on the clinical significance of that. I was curious, Dr. Stone and Dr. Sabik, for your thoughts on that meta-analysis, if you've seen it and what to take away from it. And one of the interesting points, actually, one of our cardiologists brought up that I didn't initially think of is sort of the way that people act after each of these interventions and whether they're the same or different. And the example he gave was, you know, people have surgery and they may quit smoking, they may adopt better habits. And the example he gave is he had a patient who he did a PCI on, who, you know, resumed smoking the next week, went home that day and then resumed smoking, and so on and so forth. I don't know if you have any thoughts about that outcome specifically and that question.
You know, so in terms of meta-analysis, there have been a lot of meta-analyses that, you know, have been published. It's mortality is the ultimate arbiter of things. Everybody agrees mortality is the most important endpoint. Most, not all, but most patients agree mortality is the most important endpoint. It's certainly up there. I think the most comprehensive meta-analysis was published in the European Heart Journal. And when you add up all the deaths between the studies, you get, there's a handful of different deaths. And when you say that in Excel, for example, even death was statistically significant, it wasn't statistically significant. You could see that the confidence interval that we presented didn't cross the line of unity, but you'll notice there's no p-value. And the New England Journal recognizes, and this is important for all the fellows to understand, that when you're looking at multiple underpowered endpoints, you have to adjust them if you want to actually test them statistically. So you have to do either a Bonferroni correction or a lot of other boring stuff I won't get into. But the bottom line is they're there for to give you an estimate, okay? And that's why when you've got, as Joe said before, underpowered low frequency events, sometimes it's like if you flip a coin 5 times and you get 5 heads, that's a p-value 0.03 if you want to run it, okay? But it doesn't mean that a coin only has 2 heads. So you got to look at, how about another study that flipped the coin 5 times and another one that flipped it 5 times, and ultimately you get at the truth. And I think when you look at the absolute differences in the endpoints in Excel, and then you look at the absolute differences in meta-analysis, that's the most important thing. And you find over 5 years, these differences in these kinds of patients are relatively small. I'm sure there is some difference between PCI and CABG. They're totally different techniques. Of course, one of them has a lower mortality than the other. One of them has a lower MI rate. But what I think all of the studies have shown is that in the kinds of patients, you know, low and intermediate syntax scores that are eligible for both, if both the interventionist and the surgeon believe they can do a good job, the differences are going to be small. That said, there are some, you know, what we should be focusing on is on the patients that are going to have major differences in outcomes. You show me an awful triple vessel disease, left main with 2 chronic total occlusions and an EF of 30%, and I wouldn't do a PCI on that patient if you had a gun to my head. On the other hand, you show me a patient that's 88 years old and frail and is borderline demented and has COPD and has an isolated left main lesion, a surgeon wouldn't touch, you know, that patient with a 10-foot pole. So I think there's what I call clear choices, obvious choices, and then there's a bunch of cases in in between that I think are equipoise. I don't think it's 66% like Dr. Guyton would put on that slide. I think it's probably more in the order of around 50% in which there's equipoise and 50% in which there's clear choices. And in those clear choices, it may be PCI versus CABG.
Obviously, I agree with everything that Greg said, but I do think when we look at these curves that they still are separated. And I think this kind of demonstrates the longevity of surgery. And we don't necessarily know. Now, Greg will come back and say, when you looked at syntax at 10 years, the curves start coming back again together. Now, that may be due to the population or the failure of grafts or whatever. But I think that there are, again, I don't want to harp on this point too much, but these are really complementary procedures. And it's our job, working in our heart teams and working with our colleagues to, again, offer the patient what we believe is the best solution for them. It's ultimately their decision, in many of these situations. But I think, as Greg said, I do think it's a little bit grayer. I don't think it's right in some people and not right in others. I do think there are certain benefits in surgery, particularly in terms of longevity, that only time will tell. Unfortunately, we probably won't, be able to find that out in many of these studies because they're not funded to follow the patients that long. But again, I think the curves are still separated.
Great, thank you both for addressing that. We just have one more question. I apologize, we've gone over time. We've had some great discussion. I think this is important, going to the point about a heart team. And this is, I believe, from Hunter, who's TCV lab, but he said we touched briefly on hybrid revascularization. Could Dr. Stone and Sabik comment on the role of this approach in the future and the optimal timing of each as to when each component of it should occur?
So, I think that there's observational data on hybrid, and there are some small randomized studies from Europe, that suggest in, appropriately selected patients, it's a very effective, therapy. And I think today we saw some nice examples where we have vessels that are graftable and lesions that are stentable. And so how can you combine the two with the goal of lowering the morbidity? I think that, again, we don't have enough data and understanding to perfectly understand who those patients are. But I think from an anatomical point of view, we can identify them. I think there are many ways to approach this problem. The way that I've personally approached it is I will often do the revascularization first, the Lima to LAD, for instance, and then we'll load that patient that evening, and then the next morning we'll go to the cath lab and can have the Lima evaluated to make sure it looks nice, and then have their stenting procedure and usually go home the day after. I know there are some programs that are more aggressive and do it all in one day. I personally have not had to stent first and then take to have their surgical revascularization. I know there are programs that do that. To me, I worry a little bit about the risk of bleeding in that situation because the patient is already on, the antiplatelet therapy that can't be stopped in a short period of time. But I know there are programs that are doing that with success. And I think probably the critical component in thinking about that is what is the real ischemia producing lesion? If you've got a really tight circ and a severe enough LAD, and you take the person, you do the Lima to LAD when the circ is the one driving the ischemic problems, you could have some perioperative issues. So I think those are some of the things to think about, but at least the way I think about them.
So I think we could spend a half an hour talking about hybrid approaches. I think Joe and I are both kind of high on it for the right kind of patient. It really does offer what's potentially the best of both procedures. What Joe described is absolutely true. That's kind of the classic hybrid, is you do the Lima to the LAD first and then bring the patient back. And it could be a variable amount of time from a day to 3 days to a week or even a month. And an advantage of doing the Lima to the LAD first is you can inject the Lima when you bring the patient back. So you can just make sure that it's not occluded or it's not a severely stenosed lesion with decreased flow. And then you can do the PCI. But as Joe also said, there are cases, especially the patient who comes in with an ACS. Let's say patient comes in with a non-STEMI with a thrombotic right and has a long 80% LAD lesion. It makes sense to do the right first and then to do the what we call a reverse hybrid, and then later do the Lima to the LAD. One of my major disappointments is that we spent a lot of time on getting funding from the NIH to do a trial called Hybrid, which was a 2,000 patient randomized trial in which patients with multivessel disease involving the left main or LAD were randomized to either multivessel PCI or a hybrid PCI plus Lima to LAD with a mid-cap procedure. And after trying to enroll the trial for about a year and a half, we had only 200 patients randomized, and the NIH pulled the plug on the trial because they give you all this money, but they said if you don't spend it fast enough, we're not going to keep funding you. And we just couldn't get the clinical community to answer the question, which is a real disappointment. So we randomized 200 patients, and we're following those patients for 5 years, but that was only a 10th of the 2,000 patients that we were powered for. And we were powered to show that the hybrid procedure was better than just multivessel PCI for long-term 5-year MACE, including revascularization as an endpoint. And I think that that would have been a real boon to the surgical community because it would have taken some of these multivessel PCIs and added a hybrid component to it. So it's too bad we couldn't get it done. But the last question I want to throw it back to Joe, and I want to ask Joe, because I know you have opinions on this. What are your opinions, though, of a minimally invasive Lima to LAD compared to a standard open sternotomy? Is it as good a procedure?
So that's a great question, Greg. And I have to admit, I started doing those back in 1996, so you can all tell how old I am. And I remember the original, presentations that Mike Mack used to give and got me very interested in it. And I think one of the difficulties of it, if you remember back then, we went from doing sternotomy, on pump, arrested heart CABG, to doing mini thoracotomy, off pump CABG, which was kind of a double leap. Obviously the way that probably would have been the better evolution would have been to go from sternotomy, off pump, to mini thoracotomy, off pump. But that's not the way it happened. And so I think that there were some issues, with mid-cap, but having done, many of these, through my career, I feel very comfortable, doing a little mini thoracotomy, Lima to LAD. But, having said that, if a person doesn't feel comfortable, I think a Lima to LAD through a sternotomy off pump's a great operation as well, because we know for the vast majority of people, a sternotomy is a very well tolerated incision. But having done it over, over 2 decades, I still enjoy doing Lima to LADs through mini thoracotomies.
Great, thank you. I think we can wrap up. We're 20 minutes over. I apologize for that, but great discussion from everyone. And I really appreciate all the panelists, especially Dr. Stone and Dr. Sabik, for joining us. We'll have the recording of this whole session up on the TSRA YouTube channel. And again, thanks to everyone for coming, and thank you, panelists, for joining us.
Great.
Thank you.
Thanks for having us.
Much.
Bye.